hearing will now come to order. Thank you all very much for being here today. I'd like to recognize that there is a group of high school students from Beijing, China, with us today. And thank you very much for being here, and I hope that you find this experience edifying for your future studies. And I thank the witnesses for being here and for traveling in some instances, long distances. In the Internet age, most of us take for granted being able to rapidly and seamlessly share information with someone across town in another state or on the other side of the world. We also take for granted the ubiquitous integration of information technology in our workplace, in many other aspects of our lives. In contrast, the healthcare industry is still surprisingly paper-based and is largely unaided by information technology. Medical treatment in this country often involves state-of-the-art technology. However, physicians and other healthcare providers have been slow to adopt health IT systems and electronic health records, or EHRs, and are still keeping track of our medical information the same way they have been kept historically. The use of information technology has real-world implications for the cost and quality of healthcare. Currently, providers may order a duplicative test because previous test results from another provider are not readily at hand, or they may miss a harmful drug interaction because of a patient's full prescription drug record is not available. According to most estimates, a fully interoperable health IT system could save us billions of dollars in healthcare costs each year. In addition, greater use of information technology could prevent some of the medical errors that, as reported by the national academies, are responsible for the deaths of approximately 98,000 people each year. A key barrier to broader integration of health IT systems has been the lack of technical standards to support interoperability and protect data and privacy. Many physicians, particularly those in small practices where most Americans get their health care, are hesitant to take on the considerable expense of a health IT system that, without common standards, may not work with the systems of a neighboring healthcare provider or may become prematurely obsolete. This is the third hearing the Science and Technology Committee will have held on health IT standards since the 109th Congress. I'm very eager to hear about the progress we have made on standards, especially since the implementation of the HITECH Act. In that act, Congress included a directive to the federal agencies before us today to establish health IT standards and develop related measures to enable different manufacturers and vendors to produce software and other devices that will work with other products on the market today as well as tomorrow. Given the complexity of our healthcare system, with its myriad of players and large number of state and federal laws governing personal medical information, the HITECH Act charged the Office of the National Coordinator with a very difficult task. From all reports, the National Coordinator has done an admirable job meeting tight deadlines and navigating the needs of many stakeholders. NIST has also played an important role, lending to HHS its extensive expertise in standards, testing, and certification. However, as I am sure we will discuss today, we still have a long way to go in promoting interoperability, coordinating the many health IT projects underway, governing the standards development process, and providing direction on privacy and security. Modernizing our healthcare system with information technology is imperative for lowering healthcare costs and improving patient care, and I look forward to hearing the thoughts and recommendations of the witnesses today on how we will successfully meet these challenges. Now I'd like to recognize the ranking member, Mr. Smith, for his opening statement.
Thank you, Mr. Chairman, for calling today's hearing on development and implementation of standards and testing for interoperability of health information technology. With the enactment of the HITECH Act and other measures since our last full committee hearing on this issue in September 2007, a follow-up hearing on this topic is certainly appropriate and appreciated. Interoperability of health IT is vital to ensuring one of the greatest benefits of electronic medical records, the ability of multiple practitioners in different locations to access a patient's medical records. This access helps avoid adverse interactions, duplicative testing, and other medical errors while improving coordination of care. To maximize the potential of health IT, it is vital these benefits be available not just in a metropolitan area or a single state, but across state lines. For example, in my own congressional district, it is not uncommon for those in need of higher-level health care to seek it in Colorado, South Dakota, Kansas, and Wyoming, rather than from another in-state location, such as the larger cities of Lincoln and Omaha. It is vital electronic medical records be available both close to home and out of state. For this reason, and among others, it is appropriate NIST and other federal agencies play a role in developing interoperability standards in testing for such technologies. NIST, in particular, is a trusted arbiter of standards development and testing and has the proven expertise to assist the Department of Health and Human Services in developing testing methods to ensure technology is interoperable as promised. Additionally, we must ensure interoperability standards protect private and taxpayer dollars from being wasted on technologies which are not proven to be interoperable, not as a barrier to future innovations which could further improve the quality and coordination of patient care. Thank you again, Mr. Chairman and witnesses. In particular, I'd like to welcome our witness, Deb Bass, who is Executive Director of the Nebraska Health Information Initiative based in Omaha. I look forward to a constructive session. Thank you.
Thank you very much. Thank you very much, Mr. Smith. If there are members who wish to submit additional opening statements, your statements will be added to the record at this point. And now it is my pleasure to introduce our witnesses. Dr. David Blumenthal is the National Coordinator for Health Information Technology at the Office of the National Coordinator for the United States Department of Health and Human Services. Ms. Kathleen M. Roberts is the Associate Director for Federal and Industrial Relations at the Information Technology Laboratory for the National Institutes of Standards and Technology. Ms. Joyce Sensmeier is the Vice President of Informatics for the Healthcare Information and Management Systems Society. Dr. Dick Gibson is the President of the Oregon Health Network. Ms. Deven McGraw is the Director of the Health Privacy Project for the Center for Democracy and Technology. Ms. Deb Bass is the President and CEO of Bass & Associates. You will each have 5 minutes for your spoken testimony. Your written testimony will be included in the record for the hearing, and when you all complete your testimony, we will begin with questions, and each member will have 5 minutes to question the panel. Dr. Blumenthal, please begin. Microphone.
That sounds better.
There we go.
Mr. Chairman, Ranking Member Smith, distinguished subcommittee members, thank you for the opportunity to testify today on behalf of the Department of Health and Human Services. The HITECH Act represents an historic and unparalleled investment in health information technology, lays the groundwork necessary to pursue the President's goals related to improved health care quality and efficiency, and will help transform the way health care is both practiced and delivered. We've made considerable progress in the relatively short time since the HITECH Act's passage. Our recent accomplishments include the establishment of 2 new federal advisory committees, the completion of 3 rulemakings together with the Center for Medicare and Medicaid Services necessary to establish meaningful use Stage 1, strengthened coordination throughout the executive branch on health information technology, and the responsible obligation of nearly all of the $2 billion that we were authorized to spend under the American Recovery and Reinvestment Act. My remarks today will highlight progress that ONC has made thus far related to interoperability, privacy, and security, as well as our standards priorities for future stages of meaningful use. Interoperability and privacy and security are themes that are present throughout the HITECH Act. Thus, many of our policy and programmatic efforts focus on those themes. Established by the HITECH Act, the HIT Policy and Standards Committees both regularly issue recommendations on how best to fulfill our statutory responsibilities. Both committees include a diverse membership with representatives of various perspectives from both the public and private sectors. The Policy Committee's work on privacy and security exemplifies its major contribution, and I want to note that Ms. McGraw has been a major contributor through the Policy Committee to that work. The privacy and security of electronic health information form the bedrock necessary to build trust, to ensure that we have timely privacy and security recommendations related to our HITECH programs. The HIT Policy Committee formed an interdisciplinary privacy and security tiger team of experts comprised of members from the HIT Policy and Standards Committee, as well as from the National Committee on Vital and Health Statistics. The tiger team has already provided valuable guidance to ONC and HHS. Like its sister committee, the HIT Standards Committee plays a critical role in guiding ONC. Since its inception, the HIT Standards Committee has issued recommendations to ONC on the standards and implementation specifications that should be considered to support meaningful use stage 1 and the development and maintenance of specific vocabularies to improve interoperability. With the advice of these committees and extensive external consultation, we completed last July 3 independent rulemakings that were necessary to implement meaningful use stage 1. These rules cumulatively reflect over 2,000 public comments from stakeholders across the healthcare system. The first rule was the EHR incentive program and defined meaningful use stage 1. ONC and the Center for Medicare and Medicaid Services worked collaboratively to strike a balance that reflected both the urgency of adopting EHR technology and the challenges that adoption will pose to healthcare providers. Our approach attempts to move the health system upward toward improved quality and effectiveness, but at a speed that reflects both the capacities of providers who face multiple real-world challenges and the maturity of the technology itself. The second rule defined EHR standards, implementation specifications, and certification criteria adopted by the Secretary to support meaningful use. The initial standard set specifies several interoperability and security capabilities that certified EHR technology must incorporate, including e-prescribing according to specific standards, exchanging standardized patient summary records, authenticating users, generating audit logs, and encrypting health information according to standards specified by NIST. In the third rule, ONC established a temporary certification process. We've now authorized 3 certification bodies. In developing our certification programs, we consulted extensively with our colleagues from NIST, which has been an invaluable partner in all our efforts to implement the HITECH Act. We anticipate that future stages of meaningful use will build on the foundation we have now established and will require progressively more rigorous electronic health information exchange requirements. In order to develop those requirements, we have again asked the HIT Policy Committee to make recommendations on what meaningful use stages 2 and 3 should encompass. We anticipate that the Standards Committee will then begin to focus on the standards, implementation specifications, and certification criteria that will be necessary for future stages of meaningful use. We also expect the Standards Committee to issue recommendations that focus on strengthening the security capabilities of EHR technologies and on standards for electronic health information exchange in support of meaningful use. Interoperability will be critical to our success in stages 2 and 3. We recognize that greater specificity with respect to standards is necessary to reach our goals, and we'll be working on adopting additional implementation specifications, achieving agreement on vocabulary and code sets for particular exchange purposes, and comprehensive privacy and security capabilities for EHR technology. ONC and CMS have accomplished a great deal up to now, but much remains to be done. We look forward to working with the House Science and Technology Committee on this important endeavor, and it's been my privilege to testify before you today, and I look forward to answering any questions you may have.
Thank you very much, Dr. Blumenthal. Ms. Roberts, please proceed.
Chairman Wu, Ranking Member Smith, and members of the subcommittee. I'm Cammie Roberts, Associate Director, the Information Technology Laboratory at the Department of Commerce's National Institute of Standards and Technology. Thank you for the opportunity to appear before you today to discuss our role in standards for health information technology. Both the President and Congress have recognized that health IT is a national priority, and NIST's expertise on standards and interoperability are key to the fulfillment of the goals of health IT, such as higher quality and more efficient care, seamless, secure, and private movement of data between healthcare providers without compromise or loss of information, and fewer errors and redundant tests, to name a few. Over its history, NIST has been successful in applying emerging IT standards in many national priority domains and leveraging collaborations with industry and other federal efforts. Health IT is no exception. NIST has been collaborating with industry and others to improve the healthcare information infrastructure since the 1990s. I would like to quickly note that, as with any standards effort in the United States, there are strengths and challenges in health IT standards activities. The health IT standards development effort in the U.S. is strengthened by the robust, open process in which public and private sector collaborations are addressing the end goal of interoperable EHRs and health IT systems. The many varied partners bring their own strengths to the deliberations. At the same time, with health IT as a national priority, many standards development organizations are working to provide the standards-based solutions needed, which can sometimes lead to conflicting, overlapping, or redundant standards. A further challenge is the need to accelerate standards to keep up with the fast pace of technology advances. NIST plays a critical role by providing technical expertise early and throughout the standards development process. By leveraging industry-led, consensus-based standards development and harmonization efforts, NIST is helping ensure that the requisite infrastructural standards such as clinical information exchange, security, and usability are complete and unambiguous. NIST testing activities, including developing test tools and associated testing infrastructure, reduce the cost to help develop IT systems. First, through the early use of testing, which can accelerate standards development efforts, and second, as vendors implement systems, test tools provided by NIST help ensure that standards are implemented correctly. Under the temporary Health IT certification program, testing organizations authorized by the Office of the National Coordinator will use the NIST test to evaluate EHR software and systems so doctors' offices, hospitals, and other healthcare providers have confidence in the systems that they purchase. In addition, NIST is advising ONC on the process by which testing organizations will be authorized to test and certify the EHR systems. There's much to be done in the realm of health IT standards, so we have to set priorities. Current priority areas include security standards, usability standards, and medical device interoperability standards. NIST also advances other high-priority health IT standards as needed. NIST is actively engaged with private industry, academia, and other federal agencies, including our colleagues in the networking and information technology research and development community, in coordination of longer-term health IT standards activities to ensure that future technologies can be integrated into the nationwide healthcare infrastructure. NIST has a diverse portfolio of activities supporting our nation's health IT effort. With NIST's extensive experience and broad array of expertise, both in its laboratories and in successful collaborations with the private sector and other government agencies, NIST is actively pursuing the standards and measurement research necessary to achieve the goal of improving the healthcare delivery through information technology. Thank you for the opportunity to testify today on NIST activities and health IT standards. I would be happy to answer any questions you may have.
Thank you, Ms. Roberts. Ms. Sensmeier, please proceed.
Thank you, Chairman Wu, Ranking Member Smith, and Subcommittee members. My name is Joyce Sensmeier, and I serve as Vice President of Informatics at HIMSS, where I oversee the clinical informatics standards, interoperability, privacy, and security initiatives for the Society. It is a pleasure to be with you today before this subcommittee and alongside these distinguished panelists. I present these comments on behalf of HIMSS, a cause-based, not-for-profit organization exclusively focused on providing global leadership for the optimal use of information technology and management systems for the betterment of healthcare. HIMSS represents more than 30,000 individual members, of which two-thirds work in healthcare provider, governmental, and not-for-profit organizations. HIMSS also includes over 470 corporate members and more than 85 not-for-profit and provider organizations that share our mission. Supporting the adoption and meaningful use of health IT is a key focus for HIMSS membership, and as a nurse and a clinician with several decades of experience, I am deeply committed to improving patient safety and outcomes. It is in that vein that we have addressed the two questions posed by the subcommittee. The first question is related to the progress ONC has made since passage of the HITECH Act. Prior to passage of HITECH, and for many decades, standards development organizations used open, consensus-based, volunteer-driven processes working in silos developing health IT standards. With the passage of the HITECH Act, a new process for oversight of health IT standards has been implemented. While forward progress is being made, we would like to identify three specific areas of concern. First, data transport and basic security are focus areas where selected standards are missing, yet necessary for achieving interoperability. For example, until the recommended transport standards are identified, EHR vendors will be forced to support all available transport methods or risk developing software that may not meet future interoperability needs. This lack of guidance in the first stage of meaningful use and the standards criteria creates marketplace confusion and wastes existing resources, ultimately delaying progress. Second, we would like to express concern regarding the selection of multiple standards for the same criterion. such as the selection of 2 clinical summary standards, CCR and CCD. When 2 standards are selected, vendors and providers must choose to either support one or instead support both, which is costly, resource-intensive, and minimizes health information exchange across organizations. It is our recommendation that only one standard be selected for each criterion in future stages of meaningful use. Our third area of concern is the timing of identifying and selecting the standards and subsequent rules. Timing is critical to ensure the industry can appropriately incorporate these standards into the product development and implementation cycle. Thousands of EHR systems are currently being developed and upgraded by vendors and implemented by healthcare providers. To ensure optimal software development, testing, and safe implementation, the final rules for meaningful use and standards should be available 18 months before the next stage. The second question relates to the strengths and weaknesses of the current Health IT standards identification and development process. HIMSS was pleased that the final rule established standards criteria for supporting stage 1 of meaningful use, and specifically that structured lab test results and appropriate implementation guidance were added. HIMSS urges CMS, ONC, and NIST to ensure that all contractual engagements in the standards harmonization are coordinated and leverage the public domain work products of standards harmonization bodies such as HITSB and Integrating the Healthcare Enterprise, IHE. We also request that they complement rather than duplicate each agency's efforts when creating testing procedures, tools, services, and reference implementations, and that they embrace a transparent and open consensus process with the private sector. We also recommend that HHS publish implementation guidance for all selected standards, publish standards for data transport, financial transactions, security, and health information exchange as soon as possible, publish the process and schedule for harmonizing standards, and set up one repository, such as the National Library of Medicine, for licensure and access to all standards and implementation guides. HIMSS is pleased to see these final rules being implemented in order to put into action the legislative and executive branch intent to transform healthcare using IT. I thank you for this opportunity, and I'd be happy to answer questions, and we look forward to providing our members expertise to help transform healthcare in the United States.
Thank you. Dr. Gibson, please proceed.
Chairman Wu, Ranking Member Smith, good morning and thank you for the opportunity to discuss health information technology standards. My name is Richard Gibson. I am a practicing family physician and former emergency physician and have nearly 20 years experience in health information technology. On the status of current standards, the meaningful use final rule has been well received by providers. We applaud the Office of the National Coordinator and the Centers for Medicare and Medicaid Services for seriously considering the many comments received over the past 9 months. They have been extraordinarily responsive in making rules as straightforward and as pragmatic as possible, while still moving the country forward to electronic health records that promise to improve the quality and consistency of health care. Concerning the standards-related priorities for the futures, my comments will go to the area of helping small practices in the short term to connect to each other directly, while we await the more complete and widespread health information exchange. We need a standard for transmitting provider text notes. Providers expect to be able to review the text reports produced by other providers. Historically, these text reports have been produced by transcribing notes that physicians dictated, say, for an office visit, a consultation note, a surgical procedure, and the like. We need a specific continuity of care document or continuity of care record for these tech documents to be most useful for patient care. We need a standard for exporting and importing patient information directly between EHRs and directly provider to provider. Meaningful Use Stage 1 does not require EHRs to have the ability to export and import patient information directly to and from other EHRs. As clinicians move to electronic health records, we need to enable our EHRs to transfer patient information as easily as fax machines accomplish that transfer now. The office staff needs to be able to press a button to send information to the next physician. This concept and the next two have been promulgated by Wes Rischel of Gartner and have led to the NHIN Direct project. We need a standard directory for health internet addresses. After a provider decides to refer the patient to another physician, the provider or her staff member could go onto the internet and search for the provider's authenticated health internet address. This could be entered into the sending physician's electronic health record, which would send an encrypted packet of information directly to the receiving physician's electronic health record. Later, states will need a record locator service so that emergency departments can pull data from the patient's previous providers. We need a standard for document transfer that can accommodate providers still on paper records. It will be years before all providers have electronic health records. We need a standard that sends patient information like an email attachment so that providers on paper records can still print the information. Once they do get an EHR, the same attachment could be imported into that EHR. We need an EHR functionality requirement for quality measure reporting. Smaller practices under the current rules would likely need to seek the help of consultants to produce an acceptable quality measures report. This reporting needs to be core EHR function specified by a consistent nationwide requirement so that providers in any practice can again press a button to produce submission-ready reports on a chosen measure. We need a national model for privacy and patient consent. In Portland, we often see patients from Southwest Washington. Having significantly different privacy laws between Washington and Oregon would lead to uncertainty, misinformation, and the unnecessary duplication of diagnostic testing. We need a federal effort to convene, sponsor, and mandate development of model rules and laws that each state could take through its own legislative process. We need to set appropriate expectations on provider access controls to patient information. In our largely fee-for-service healthcare system, one cannot exactly predict which doctor or nurse will take care of them on any given occasion. Our model needs to set the expectation in the patient's mind that it is not possible to predict precisely who will need access to their record in the course of their care. Finally, we need a model for the complete health record being available to the provider. Although the provider can infer some of the patient's diagnoses from the medication list and allergy list alone, it is crucial that providers see all the medications and allergies when they prescribe. Without this guarantee, patients could be hurt. Similarly, providers need access to the full laboratory and imaging reports when they're trying to make a diagnosis. Redacting these data because they imply a certain restricted diagnosis is unsafe and could ultimately result in physical harm to the patient. Chairman Ryu, Ranking Member Smith, thank you for the opportunity to testify on these important issues. I would be happy to answer any questions you may have.
Thank you very much. Ms. McGraw, please proceed.
Okay, thank you, Chairman Wu, Ranking Member Smith, and the staff. Really very much appreciate the invitation to testify before you on the privacy and security challenges raised by widespread adoption of health IT. What we do at CDT is develop and promote pragmatic privacy and security policy and technology solutions for a health system that we really hope will be increasingly characterized by electronic health information exchange to improve individual as well as population health. And I also chair the Health IT Policy Committee's Privacy and Security team that Dr. Blumenthal mentioned, and I appreciate the thanks. It's, we're in a very good place, I think, for making some progress on these issues. We know from survey data that the public is actually quite enthusiastic about what we're doing with health IT, but they also express in equal numbers concerns about privacy. You can't have one without the other. Essentially, privacy is not the obstacle to doing all of this and getting it done. It is the enabler. And we need to consider it that way and pay it serious attention. And clearly this subcommittee agrees, or you wouldn't have asked me here today in a hearing that's largely about standards. And we'll do some talk about security standards because that's where standards really comes into focus, probably less so on the privacy side. We do have the privacy and security regulations of HIPAA, and of course states have laws as well, and those are the baseline. But we're really changing the way we're going to be moving health information and setting up new infrastructures, and so we have to consider what we need to layer on top of what we've already got. And in addition, we're talking about health information technology, not just protecting health information. And so we need to think about the strong role that technology can actually play in helping us to establish a comprehensive and flexible framework of privacy and security protections that will build that trust layer that will enable us to go forward. As I mentioned before, we're in a much better place than we were a few years ago. When we were arguing about privacy. We're still arguing about it, but we actually, the work that Congress did in the high-tech legislation has pushed us tremendously forward. And in addition, the financial incentives that are part of the high-tech incentive program give us additional policy levers to really push us into a better place with respect to privacy and security. We still do have gaps to address, of course. You know, this is not something that is ever done. We need to sort of be continuously paying attention to this. And so I'm going to talk a little bit about security, and I'm going to give some credit to one of my panelists from HIMSS. They did a survey fairly recently of large healthcare organizations that indicated that security is far less of a priority than we would hope. And this is for large organizations. And just to lay out some examples, fewer than half conduct the annual risk assessment that the HIPAA security rule requires. 58% of these organizations say they actually don't have security personnel, and 50% reported spending 3% or less of their resources on security. And again, this is a survey of large organizations and not small practices, although as you'll see in HIMSS's written testimony, they're doing this survey next. I think those will probably be some very sobering numbers, but they are a lesson for us. We really need to be quite serious about this. When you think about what the root is of the public's concern, a lot of it is about inappropriate access to records for which security is a primary gatekeeper. Now, we know that with respect to what an electronic health record has to have in order to be certified, there are functionalities that have to be present, and Dr. Blumenthal mentioned some of these, the ability to encrypt data, the ability to generate an audit trail, but there's actually no clear requirement to use these functionalities. The HIPAA security rule is very flexible. It says that some of them are addressable. Similarly, in meaningful use, you have to conduct a risk assessment and address any deficiencies. But here you have the functionalities in the record, and we're not being terribly clear with providers about using them. I think that is a major deficiency. We need to raise our expectations, certainly with respect to small providers. A piece of health data is sensitive no matter who's holding it. If it's a large institution or a single physician practice. But in terms of the level of resources that the smaller physician practices can put into this, clearly we need something that is scalable and something that works for them now with a glide path to greater expectations down the road. So I'm reaching the end of my time. My written testimony has a number of other gaps that I've discussed there, including the HIPAA de-identification standard. We're seeing an increasing emphasis on access to and use of de-identified data for a range of purposes. Certainly when data is de-identified, stripped of identifiers, it's much more privacy protective. But we actually don't have a legal prohibition against re-identification that we can enforce. And that's something that Congress could actually do to really help secure trust. Again, the de-identified data issue is a big one. HHS is doing a study. I think after that comes out, we ought to talk seriously about what the right next steps are. So I'm going to close. I had a really ambitious oral statement here for 5 minutes. As I noted before, this is assuring privacy and security to the level where we've got the trust of the general public in what we're trying to build here really is an ongoing commitment. And the fact that you've put privacy and security on this agenda, even 2 years after high tech, when there's a lot of people who said, well, didn't we do this already? Shows that you agree, which is terrific. So thank you again for the opportunity, and I'm happy to answer any questions that you might have.
Thank you very much, Ms. McGraw. Ms. Bass, please proceed.
Thank you. Chairman Wu, Ranking Member Smith, committee members, staff, and guests, thank you for the opportunity to present on this very important topic. I'm honored to be among such esteemed members of the healthcare community, my fellow testifiers, all who are contributing so much to the advancement of healthcare reform. In preparing for this testimony, I spent considerable time reflecting on our experiences in Nebraska. There is a great deal of expert dialogue on the topic. Certainly, hearings like this provide additional subject matter expertise that will surely benefit the ongoing development of standards for interoperability and information security and healthcare reform in general. It is clear this committee has significant data and information at its disposal to continue its pursuit to develop solid and workable standards. I would like to focus my testimony on principles Nebraska has implemented in this arena and respectfully share with you the lessons that we've learned as we directly applied the success of those efforts for those at the Office of the National Coordinator who are developing these critical standards. There are 3 areas that have contributed tremendously to Nebraska's success in implementing the federal health care initiatives of achieving meaningful use. 1, extensive and persistent stakeholder engagement. 2, physician engagement. 3, sharing the knowledge among the states. As President CEO of Bass and Associates and Executive Director of NEHI, the Nebraska Health Information Initiative, I've worked closely with the NEHI team and project members to ensure we engaged key stakeholders across our state. We knocked on doors, developed educational materials, launched community-based consumer education campaigns. We spoke in cities and across rural Nebraska, Rotary clubs, state associations, and Chamber of Commerce meetings. In short, no stone was left unturned in our efforts to engage citizens across the state. The Office of the National Coordinator has done an excellent job of reaching out to the stakeholders, including our own opportunity to host Dr. Blumenthal in his recent visit to Nebraska. Dr. Blumenthal took time from his busy schedule to tour the NEHI-enabled facilities and witness the successful health information exchange up close. I'm certain his travels are extensive and require a great deal of effort, but the benefits of these stakeholder visits across the country are immeasurable. As ONC develops its next set of standards, I strongly urge them to continue to avail themselves of stakeholder conferences, meetings, and other opportunities to demonstrate their continued support of these standards. And I express appreciation for the efforts states make to understand, implement, and adhere to these guidelines. The stakeholder engagement is especially important as standards are being examined and released, and particularly those supporting the ONC's efforts to develop technical standards to address interoperability demands. At its March 24, 2010 HIT Standards Committee hearing, ONC identified the need to support a broader set of stakeholders and providers in information exchange. This, I believe, was another critical step in the right direction to encourage stakeholders. We have included our circle for pharmacists, dentists, chiropractors, and school nurses. NEHI was implemented using the most current available standards, and we remain committed to conforming to standards as they are developed. We will make every effort to pursue the conversations and affirmations from NEHI participants in setting those standards to guarantee the ability of HIEs to operate with the least amount of impact to daily operations. Recently, I met with a state that while it possessed all the components to successfully build an HIE, it's struggling with the critical issue of physician adoption of their HIE. Our conversations around solutions to reverse this trend revealed how difficult it is to move forward on interoperability of electronic records without fully engaged physicians. At NEHI, we're fortunate to have Dr. Harris Frankel, a respected Omaha practicing board-certified physician who serves as the NEHI visionary. In this capacity, he is able to reach deep within the physician community as a respected leader and as one of their own. I cannot tell you the number of times Dr. Frankel's reach within the physician community allowed us access to respected physicians who became champions of NEHI and therefore supported interoperability across the healthcare spectrum. Dr. Blumenthal, as a practicing physician, enjoys this esteem as well. His continued contact with the physician community toward adhering to standards and interoperability of electronic records will be the cornerstone to engaging this critical constituency and ultimately one of the key success factors of healthcare reform. Finally, I believe the Office of the National Coordinator should continue to be a dedicated resource for current information and offering a collection of lessons learned and best practices for states to rely upon. A national repository of best practices from all states would be a helpful guide in that direction. We at NEHI have offered, and to date 16 states have accepted, our privacy and security policies for states to utilize and as an example for drafting their own policies. Sharing this information has engendered goodwill, trust, and a shared commitment. I urge the ONC to facilitate the sharing of knowledge among states throughout the reform effort. The ONC's support grant opportunity administered through RTI is an excellent example of encouraging states to cooperatively identify barriers and share knowledge in overcoming them. Chairman Wu, Ranking Member Smith, and members of the committee, thank you for the opportunity to testify today. Your commitment to reach out to those who shoulder the largest part of healthcare reform effort is much appreciated and will go a long ways toward its continued success. I look forward to answering your questions. Thank you.
Thank you, Ms. Bass. And now it's in order for questions, and the chair recognizes himself for 5 minutes. Dr. Blumenthal, in Dr. Gibson's testimony, he notes that there aren't enough IT implementation professionals to help with the implementation of health IT of health IT systems. Can you tell us what the Office of the National Coordinator has done to provide assistance to educational institutions to expand the health IT workforce? And Dr. Gibson, can you tell us what other assistance may be helpful to educational institutions to help with workforce needs? Dr. Blumenthal.
Thank you, Mr. Chair. We agree with Dr. Gibson, and in fact, the high-tech legislation very wisely encouraged us to support the training of health IT professionals. We have provided funding to 84 community colleges around the country to train a group of IT professionals who will be certified as competent to assist with the installation and maintenance of information technology, but also to help health professionals and hospitals with redesigning their workflow to take advantage of those new technologies. We also have a series of curriculum development grants, one of which has gone to the Oregon Health Science University to develop the curricula for these community college programs. And we have developed a certification exam through a contract, a grant actually, with another university to be able to certify these professionals. We expect to train in excess of 40,000 new health information technology professionals. The first class has enrolled in community colleges as of this fall, so they will be graduating in the winter and in the spring of this year. So that'll be in time for meaningful use, stage one. It would be nice if they had been trained before the High-Tech Act was passed, but we are trying to live within the realities that we face.
Thank you very much. Dr. Gibson?
I think that the training. Thank you, Deven. I think that the training that has been prescribed is excellent, and I think it will help a great deal, and I believe in that. Oregon is a proud leader in training many of those people at the community college level. I think practices will find them helpful, and it should address some of the need. I'm concerned just with the many hundreds of thousands of eligible providers that the timeline might be a bit longer than we expect, but I think we're going all in the right direction right now on that.
Terrific. Thank you very much. Last week, the Office of the National Coordinator released a framework that will coordinate future work on interoperability and standards. How will the framework identify priorities and allow for stakeholder input and interface with the Health IT Standards Committee?
The framework is a means to an end, Mr. Chairman. Actually, our priorities for developing standards are identified by the meaningful use framework, by the requirements for meaningful use that health professionals, providers across the country have to meet. We work backward from the meaningful use requirements to identifying the standards, the capabilities that electronic health systems have to have. And that actually gives us guidance, which the Health IT Standards Committee then works on to recommend the standards. So it's really an ends-driven process. We focus on outcomes, the health of patients, and what the record has to do in order to improve the health of patients. And that gives us guidance as to standards. The framework you refer to is a method of producing those standards. So once we know which standards we need, we then go to the framework and say, what's the process for standards development? That process needs to be inclusive. It needs to be inclusive of other federal agencies like NIST, needs to be inclusive of stakeholders, needs to be inclusive of standards development organizations, the profession, and all the many voices that are interested in our standards work. But ultimately, it's not a standards-driven process, it's a healthcare-driven process, and we are trying to put in place the requirements for records to make them tools to improve the health and safety of the population.
Thank you. And Ms. Roberts, you mentioned in your testimony that NIST is working with Health and Human Services Office of Civil Rights to develop baseline security configuration checklists, as well as conducting outreach and awareness about security challenges for health IT. Can you focus down on the specific challenges for smaller practices in implementing these security regulations?
Yes. One of the things that the very first thing that the small practice needs to do is a risk assessment, determine what the risk is in the environment that they're in, and then based on their risk assessment, they can choose which controls they need, which security controls they would need to put in place in order to meet the security requirements spelled out in the security rule. So it's sort of graduated. If the risk is fairly low, then they don't have as many controls they need to put in place. But larger practices have more risk, and they'll have to put more in place.
Thank you. Thank you very much. Mr. Smith, 5 minutes.
Thank you, Mr. Chairman. I'm wondering if any of our witnesses could comment on how perhaps consumers could be empowered through health IT. And I understand, we want to maintain privacy, but I think that consumers, and if they become patients, would be empowered and I think more effective in managing their own health care, perhaps assuming better health habits and so forth through health IT. And if anyone would wish to talk about that.
Yes, I'd like to address that. I think that electronic health records really will allow patients to be much more involved in their health care than they are now, because I believe ultimately they will have access to the full professional record. Not a diminished record that has only part of it, but ultimately they'll have access to all their laboratory results, diagnostic imaging reports, problem lists, medication lists, allergy lists. They'll be looking at the same data that their providers look at. And with the use of the Internet so that they can bone up on what the professional diagnoses are, I think they'll come to the table saying, I've read about this, I have concerns about how this treatment might affect my lifestyle and that sort of thing. So we're quite looking forward to having patients more on an equal footing with their providers because of the spreading of electronic data into the home.
The law has always required providers to provide patients with a copy of their health information if they ask for it, but Congress took some significant steps forward in that regard to make sure that that happens by being very clear that when a provider has an electronic health record, that copy has to be electronic. And then with respect to the meaningful use criteria, there are a number of provisions that are required for meaningful use that involve sharing data with patients, and not just when they ask, but giving them a discharge summary, for example, and instructions and a summary of their care. And I suspect that in stage 2, this will be enhanced even more. And the other thing that Congress did was to say, not only can you get your electronic copy of your record, but if you want your provider to send it to your personal health record, if you've opened up one of those, either because the provider gave it to you, your health plan sponsors one, or you've signed up for one from an internet company like Microsoft or Google. So I completely agree with you, and it's absolutely privacy enhancing to give people copies of their data. It helps to reduce errors because patients catch them.
I would like to comment on real-life examples that we've seen in Omaha. We've had an operational HIE now for over 18 months and throughout the state of Nebraska, not just Omaha. Our opt-out rate, we are an opt-out platform. The opt-out rate has been anywhere between 1 and 3, a little over 3% of the general population. I think Nebraska has been viewed as somewhat of a conservative state. So I think that speaks well to how well the consumer is anxious to have this opportunity. Many times when we educate them about their decision that they make at this point, at the point of care, their comment is, so if I sign up for this, I'm not going to be handed the pencil and clipboard every time I see my physician. I can say it, it's interesting how many times that comment is made. I also have had situations, and I think sometimes we think it's a generational thing, that the older generations are more concerned versus the younger generations are very interested in having this information. I've had elderly individuals that come to the office, and my receptionist will call me and she'll say, there's one of those individuals out here. They had opted out of the system, and then they educated themselves, and they were adamant to be back into the system, and they asked me, how long will this take for you to do the processing? And we've made it difficult. Once they've opted out, we make it difficult for them to get back in. But they want to know, how long is it going to take for me to get back into the system now that I understand what this is all about?
Okay, what about then connecting the care and consumer, their own detection of perhaps what might be necessary, or even with the advice of their provider, tying that to the financing? I think that there's not, anecdotally, I think that there is not enough access to the dollars associated with the care over the phone. I mean, when you have providers say, well, we don't provide that over the phone, is there any way we can tie that in? I mean, I would think there would be less concern about, but still, we need to be sensitive to the privacy issues, but to involve consumers more in the financing of their care, whether it's third-party payer or not.
I can go on to comment about some of these real-life examples. One of the individuals that came to the office that insisted to be opted back in as soon as possible had just had to experience a second round of testing because he left one health system and went to another health system, and he received the bill for that. And he said, so I understand if I sign up for this, this is not going to happen any longer. And we said, yes, he got it. And I think there's many out there that as we're having to pay for more and more of our health care costs, are becoming much more aware of what it costs and duplicate testings and how to avoid them.
Okay.
I would just like to speak to the standards aspect of that. There are standards available from the HITSB work products for consumer empowerment, which would enable their personal health record data to be exchanged with the electronic health record. So work is there to support your concerns.
Okay. Thank you.
Thank you very much, Mr. Smith. Dr. Gibson, you noted in your testimony that implementing EHRs is stressful, somewhat stressful for physicians, particularly in small practices, and that further it's essential that we be able to transfer patient information as easily as fax machines accomplish that transfer today. What are the biggest challenges in making this data transfer that easy for physicians, particularly in small practices?
That the technology needs to be such that the provider himself or herself or their staff can do it directly, that they can do it without perhaps having a health information exchange in their local or regional area, and that's the key point. If an electronic health record for a small practice is going to exchange with a health information exchange, that electronic health record will still need to export those data. And the point of my testimony is just let us make a requirement that electronic health records can export and import those data directly, because most care occurs among providers who are known to each other. So if you're in a John Day, Oregon, your family doctor and perhaps a surgeon are likely to be in the same town. They're going to be known to each other and to the patient, and so the need is for the office of the family doc to be able to send the records to the surgeon without requiring that state of Oregon provide a health information exchange. We will ultimately. So my comments address the shorter term need of saying let's require in the next round of standards that the EHRs have to do it so that you just put in the address of the receiving provider and then it's done without requiring a third party to intervene.
Thank you very much. Ms. McGraw, there are a lot of personal data openly available today. And we de-identify some of that data. You address the re-identification phenomena and potentially the need to impose some sanctions for re-identification.
Yeah.
Can you unpack that set of ideas a little bit for us? This is a hot issue for us.
Yeah, I rushed through it a bit. So we've got a standard in the HIPAA privacy rule for data de-identification, and there's two prongs to it. One is what's called a safe harbor, because it's fairly easy for people to implement. There's 19 different common identifiers that you must strip out of the data in order for it to qualify as de-identified. And it doesn't mean that it goes down to zero risk of re-identification, but the risk is supposed to be very small. And then the other mechanism, if you want to be able to leave some identifiers in, like dates of service, for example, are often needed in research, but other identifiers are not. So you can use a statistician, and they can do their math magic to make it so that it meets the same standard of having a very low risk of re-identification. So that's already in the law. The problem, I think, is, number one, the safe harbor was created more than 5 years ago, and now, as you mentioned, Chairman Wu, there is a lot of other personal information widely available on the Internet, and re-identification, the risks are about what the recipient might have access to in order to connect the dots and put that data set together in a way that makes it possible to re-identify individuals. And so we tend to treat in the law de-identified data as though it's reached some sort of holy grail moment of posing no risk at all, regardless of who gets it or what data that they have access to. So we need to rethink the standard. I think that's what HHS is focusing on now at the directive of Congress. But even if we tighten the standard as much as we possibly could to still make that data more widely available, it has lots of important purposes in both in healthcare as well as in business analytics. If, in fact, that data goes to an entity who then re-identifies it, puts two and two together, we don't right now have a mechanism in the law to reach them to say, you weren't supposed to do this. Right now, you would hope that entities, when they release the data, actually contractually require the entities not to re-identify it. But even that, if it happens, because it's not required to happen, that's the extent of accountability is only through that contract, and usually only the contracting parties, not law enforcement or governmental authorities or even an individual under a private right of action.
Does anyone else want to comment on this re-identification problem?
Mr. Chairman, it's very much on our mind as we go forward at the Office of the National Coordinator. We do have a study of this ongoing. I think we're going to have to look at the science of de-identification and identification, if you will, and come to consensus on what level of risk we can tolerate for re-identification, and then what level of removal, what kinds of removals of information are required to get to that level of risk. And that's going to require that we continually look at the Internet and the information that's available. And it's not going to be a one-time judgment. It's a judgment that we're going to have to continue to make based on how the technology advances. But it is something that we recognized is critical to assuring public trust and enabling some of the most valuable uses of information to go forward.
Thank you. Earlier, we had a sidebar discussion about proper compensation for meaningful use. There will be compensation for meaningful use from Medicaid and Medicare. To what extent would compensation from private insurers be helpful in the uptake of healthcare information technology?
Well, we think at the Office of the National Coordinator would be extremely valuable. The federal government does pay for probably 40% roughly of the healthcare bill, but there's another 60% that benefits from the availability of health information technology. In August, we actually worked with some of the major insurance companies to help to get them to agree to begin to incorporate meaningful use in their pay-for-performance programs. So the United Healthcare, Aetna, WellPoint, all agreed that they would start to look for meaningful use as a indicator of either high performance or quality improvement, and that they would, and actually United Health Group said that they were going to launch a pilot project to make loan funds available in 2 states for physicians who want to adopt electronic health records.
And how much of a bump are the private insurers considering for meaningful use?
You mean how much are they willing to put on the table? I think that remains to be seen. We are going to keep working with them. We're actually going out to meet with the Blue Cross Association in a month or so to talk about the same issue. What I can assure you is that we will continue to work with them to try to make sure that, or try to assure that their contribution is a meaningful contribution.
Ms. Bass.
Thank you, Chairman Moo. I'd like to comment on this as well. Blue Cross Blue Shield of Nebraska has been a significant player in the implementation of HIE, and they currently they pay a license fee of $25,000 a year plus $1 per member per year, and we're talking about increasing that levy to $1.50. So they have been an active participant, but I will tell you that we have also met with the other providers or the other payers in the state of Nebraska, and they are somewhat hesitant to play a role in this. And their answer, understandably so, is that, you know, we deliver health insurance on a national perspective. So we're looking for a national strategy versus having to accommodate state by state. So again, to be able to help us find a way around that obstacle, it's critical that we have them participate. And then to go back to your previous point about the de-identified, re-identified data, that was a huge issue for us as we developed our privacy and security policies. And hence, and we were talking about this prior to the R and High-Tech Acts. So originally we were designed for treatment and payment purposes only. But even to this point in time, we are only providing eligibility verification for Blue Cross Blue Shield, and it's because of this fear of re-identification, and we have excluded all research for that fear.
Thank you. Dr. Gibson, my understanding is that there is a private insurer in Portland, Oregon, which provides some compensation for use of health information technology to private providers. Can you tell us something about that?
I'm sorry, I'm unaware of that. I'm sorry I'm not able to contribute. Can you give me more?
I think it's the Providence Group. I'm not completely confident of that.
Okay. That they would provide funding for sharing of health information?
Yes. That is, if the record, if reimbursement is submitted to Providence, that Providence would provide a small bump in the reimbursed amount.
Well, Providence Health Plan does provide, I apologize, Chairman, you're absolutely right. Providence Health Plan does provide, give extra 1% payment to physicians if they have an electronic health record. Absolutely. Thank you for reminding me.
It's a 1%.
1%.
Okay. Thank you very much, Dr. Gibson.
Thank you.
Mr. Smith? Mr. Smith, do you have any further questions?
Just one briefly. Dr. Blumenthal, I know that it's my understanding that some large organizations, healthcare organizations, kind of are early adopters, and they've been innovative. How do we dovetail what they've already done? How do we take that into account, without rendering the progress that they've made useless, or certainly the expenditures that they've made worthwhile?
Well, fortunately, though the United States lags behind most of the Western world in its adoption and use of information technology in healthcare, there are some large organizations that are leaders in the United States, and I think are as far along or further along than any place else in the world. And these are organizations whose names we would all recognize, places like the Mayo Clinic and the Cleveland Clinic and Intermountain Healthcare in Salt Lake City. So that's good news. They will, because of their foresighted investments, be eligible for meaningful use compensation just as any other organization would be. We are trying to take advantage of the lessons they have to learn, they have to teach, and we certainly engage in them. We engage them in our policy committee. We have representatives from Intermountain on our policy committee, for example, as well as from the Registry on the standards committee, someone from the Registry program, which is in Indianapolis, which is another leading leader in health IT. So we take advantage of their input on an almost daily basis in terms of our policy development. Our learning, our effort to enhance the adoption of health information technology works to a large degree through a program called the Regional Extension Center program. This is a program that's actually modeled on the USDA Agriculture Extension program, and its goal, if I can kind of overgeneralize and oversimplify, is to bring the latest information technology to the family doctor the way the U.S. Agriculture Extension Service brings technology to the family farm. That program is oriented towards small practices and underserved areas, including rural areas, and to critical access hospitals. Now, they will be trying to channel the lessons that have been learned elsewhere in our health system to make them available to the least well-resourced, least IT sophisticated members of the healthcare community. And that's why we've focused them on small primary care practice in underserved areas and critical access hospitals. But they will create learning communities that we hope will take advantage of the latest progress that's been made.
And then very briefly, we've heard a little bit about the ARA funds. They're going to go away. And Dr. Blumenthal, can you speak to how that might be addressed long term? I mean, can we achieve a lot with a one-time expenditure as opposed to maintaining the need for a budget line item in perpetuity?
Well, one way to think about the ARA funding is as a pump primer. And ultimately, the use of health information technology, in my view, is a part of the business of healthcare, and it should be a private sector responsibility. I think the investment that the Congress and the administration have made was meant to correct a market failure, which stemmed from the fact that we don't sufficiently reward providers of care for high performance, lower cost, higher quality. We pay them by piecework, whether it's a high quality or high cost product or a low quality product. So there wasn't an incentive to pay the money that's required in order to get health information technology. So I think we needed to prime the pump. We will very soon, I think, see that it becomes an essential part of providing care to the American people, one that physicians, nurses, healthcare institutions don't feel they can afford not to have. And at that point, I think the federal government and my office can pass the baton to the professional community, to the hospitals, the nurses of the country, and the market will take off and do its own work for the American people.
Okay.
I thoroughly agree with Dr. Blumenthal. If you survey providers a year after they've gone on an EHR, 90% of them will say never go back to paper. So they realize the benefits. It's that intervening year that I think that the priming of the pump that Dr. Blumenthal's office and CMS have provided for is adequate, to the degree that it will stimulate doctors over. Once they get over, there'll be a network effect. They won't be able to communicate as easily with their colleagues without an electronic health record. I think that consumer pressure will be such that, gee, doctor, don't I have access to your records? Well, if not, why not? So I believe that that will take over, and I don't see a long-standing line item in the budget for this.
Mm-hmm. Ms. Sensmeier?
Yes, another thing to note is since 1994, HIMSS has sponsored the Davies Award, which awards organizations and public health systems, community health organizations, and private practices for implementing electronic health records. And it's notable that they all identify the return on investment for them. I mean, it is certainly a huge investment up front, but at the end, they have improved their processes, and really all of them have achieved cost savings. So that's noteworthy as well. And two of them are from your state of Oregon, two of the winners. Chairman Wu, I'm sorry.
Ms. Bass?
Thank you. We take that call from the ONC to be sustainable within 4 years very seriously. And we are already beginning to see some of the opportunities, just as the web services came from the World Wide Web. We are beginning to see HIE services. And I visited with the group this morning about some of the things that we're doing to be able to generate revenue. I can go into detail on some of those, but we're very confident that we will be seeing many opportunities to create revenue through the Health Information Exchange.
Okay. Thank you, Mr. Chairman.
Thank you. Many of you traveled long distances and also spent a lot of time and energy preparing your testimony. And I want to give you all an opportunity to add anything to your testimony that we have not asked about today.
I just want to express my gratitude to the Congress for putting in place the HITECH Act. I think it's a superb piece of legislation. It's, as I've gotten to know it and trying to implement it, I've been impressed at how it addresses almost all the major issues that we need to address with respect to the implementation of an electronic health system in the United States. That's not to say it's going to be easy, but I think you've given us a great start. So my appreciation to you and your colleagues.
Thank you, Dr. Blumenthal. Anyone else?
I would like to echo his comments as well as to thank the committee for recognizing this role in health IT and ensuring that we're involved in a partner with ONC and making this go forward. Thank you.
We appreciate this work. Ms. Sensmeier.
Thank you, Chairman Wu. I just would like to briefly go back to your comments on the workforce and want to emphasize how important that is, and also recognize the role of nurses in this process. I mean, it is often a silent voice, and there are 3.1 million of us out there. And there are approximately 9,000 informatics nurses working in the U.S. helping to implement and lead these projects. So it's critical work, and I appreciate the support that you have put to the workforce efforts and making sure we all have the competencies for informatics we need to do this work.
Thank you very much.
I also would like to commend Congress for the HITECH Act, the Meaningful Use Final Rule, the remarkable cooperation between the Office of the National Coordinator and the Centers for Medicare and Medicaid Services, who've brought order out of chaos within electronic health records. We now see where we need to go. I think it'll be very challenging to get there. I also want to state that I believe that this information technology is crucial in terms of bringing down healthcare costs in the long run. We are not the answer. We are an enabling technology that ultimately will allow all the care to be subject to review in comparison to national scientific standards. And I think it will be a useful technology in the long run as we work on the challenging problem of healthcare and healthcare costs and quality. Thank you for allowing me.
Thank you very much. Ms. McGraw.
I feel like I got some good opportunities to speak, so I don't have anything to add, but happy to follow up with additional information, such as ideas about the de-identification, re-identification issue, the security issues I raised, and anything else in my testimony.
Thank you. Ms. Bass.
Oh, sorry. I, too, would like to echo thank you for the work that you've done. It's been outstanding. One point I do want to make about when we're talking about enabling EHRs to talk to other EHRs, to be aware of the interface fees that can be obstacles, and I just wanted you to be aware of that piece of information. Also, I'd like to close with the fact that I, too, was a registered nurse for 20 years before I went into technology, and I'm very thankful that because of the work you're doing, people are no longer asking me what technology has to do with nursing. Thank you.
Thank you very much, and thank you all for appearing before the subcommittee this afternoon. The record will remain open for 2 weeks for additional statements from members and for answers to any follow-up questions the committee may ask of the witnesses. The witnesses are excused, and the hearing is adjourned. Thank you all very, very much.